Good morning. It's really great to be here to talk about a subject that we all care so much about. Truth be told, I wrote my dissertation on home health services when I was at Hopkins, so I feel like I have come full circle because I don't get a chance to think about home health specifically all the time, but it's great to return to this issue. I want to thank everybody for inviting me. And Mr. Martinez, I want to thank you in particular for bringing this to home for all of us who tend to get very wonky and talk about policies and numbers and all the things that I'm about to do. And really, in the end, it's not about any of that. It's really about the people who are served by the program. So I am going to quickly touch on Medicare and Medicaid as programs and what they do. But I think that Robert covered that perfectly in the last discussion, so I don't want to spend too much time on that. I'm then going to talk about the people and sort of the characteristics of home health users, because I think that sort of brings a little bit of numbers to the people who get care and helps us understand who the program serves. And then I'm also going to talk about the challenges that lie ahead in thinking about home health in the future. Bruce, I was grateful to see the spectrum that you laid out in the beginning, because I had debated putting up one myself, but you did a better job, of course. And I will be focusing on the middle part of his spectrum, which is the home health part. I'm going to focus primarily on Medicare and the people, not only because they are the bulk of people who use home health, but also we have the best numbers about the Medicare program. So let's take it from there. I know that you all are going to be talking about what home health should look like in the future. I'm going to set that up just a little bit, but I am confident that the answers are going to emerge over the next couple of days, so I have too much humility to try to put them out for you now. So Medicare home health, the basics. I actually think I'm not going to say much about this, because you have heard what I'm about to say in terms of who is eligible for home health services, what services they get. You've heard about the Supreme Court case, and Judy Stein is here, who played an active role in that Supreme Court case that changed the way people think about and coverage rules with respect to home health services. I would consider this the Medicare silo in terms of home health, and I think that's going to be a refrain in the next couple of days, and one that was talked about in the opening panel. There is the Medicare silo in terms of home health services. There is a Medicaid silo in terms of home health services. They periodically interact and overlap, but they're not so well integrated. And then there's sort of what people pay and what private insurers pay. So this is sort of silo number one, and again, I'm not really going to talk about it. And then guess what? Here's a little bit more about that first silo that, again, I'm not going to talk about, because Robert not only talked about benefits and coverage, but he also talked about what is not covered. And so there we go. And he also talked about home health services. So I think you all have a grounding on Medicare home health. And I'm now wanting to talk about Medicaid a little bit. Medicaid is a little bit more complicated. I'm a Medicare person. Medicare is complicated in and of itself, but Medicaid, you have all the states and all the different rules, and it adds a layer of complexity that is almost impossible to characterize. Medicaid, to be eligible for the home health benefit, obviously you have to be eligible for Medicaid, so therefore it is a program really for low-income people. Many of the low-income people who get home health services are also covered under Medicare. Medicare is always primary. Medicaid is secondary. Medicaid we think of as a program for long-term care services and supports. Home health is not, in this framework, not really long-term services and supports. Home health is a mandatory benefit. Home and community-based services are optional. So it is sort of at the tip of the iceberg in the Medicaid framework. It is an important benefit. It is mandatory, but it is not what we normally think about, I think, when we think about the array of services that people can get under Medicaid that they cannot get under Medicare. Even though home health is a mandatory service under Medicaid, limits do apply. And here you can see that states have the option to impose cost limits. 5 states do. Service and hourly limits, 25 states do in DC. So it is a service that is mandatory but with constraints. The other tricky thing about both Medicaid and Medicare is it's getting harder to keep our eye on the prize because many of these services are now being provided in managed care or capitated arrangements. So that it has been marvelous to be able to track what Medicare spends its dollars on in the traditional Medicare program because we know providers submit claims and Medicare pays those claims. As we move more and more healthcare services into capitated arrangements under Medicare and in Medicaid, it's a little bit harder to know who is getting what, how much home health they're getting, and what we are paying for these services. So there may be opportunities in managed care, but there are also trade-offs because it's a little bit harder to track down. In terms of the dollars, so this is just home health spending, and I wanted to give you a sense of who's paying for what. And Medicare is the primary payer for home health services. Again, I'm reminding you that this is home health pretty narrowly defined. I see some of you are taking pictures. I'm happy to make these slides available to you later. This is narrowly defined. It's not long-term care. But it comes from the National Health Expenditure Account data. The one caveat I'll say is they include home health agency spending on hospice services in their numbers, so it's a little bit inflated and maybe higher than some of the numbers that you are used to seeing. Still, let me just back up for 1 second, sorry. So this is Medicare and Medicaid, and then we have out-of-pocket. I want to say I think that we are pretty bad at calculating the financial burden that families pay. I'm from the Kaiser Family Foundation. We do a lot of work on out-of-pocket spending. We care deeply about that, and we have put out recently our new charts and facts about what people in Medicare are paying out of pocket. The main data source that we have is something called the Medicare Current Beneficiaries Survey, and it is admittedly weak specifically on home care services, which includes home health. So my guess is we are generally understating what people are paying for home health services, but this is what comes from the National Health Expenditure Accounts. I just wanted you to keep that in mind because I think the balance of financing is going to be an important one as we think about future challenges. At the moment, home health is a relatively small share of both Medicaid and Medicare spending, federal spending. As you can imagine, inpatient care on the Medicare side is a much bigger share of the total. On Medicaid, because managed care is such a large share of the total, it's much harder to see the allocation of specific services. We do know that nursing home services account for a relatively large share of the total. Now let's talk about who is getting home health services so that as you go along in your discussions, you have a clearer picture of the population that's being served. So here we're looking at Medicare home health use among people with chronic conditions and among people with functional impairments. And as you can see here, the rate of use, home health use, rises with the number of chronic conditions. I don't think that would surprise anybody. The more problems you have, the more likely you are to use home health services. And home health use also rises with the number of functional impairments, which raises the question about how good a proxy is functional impairments as a measure, as an indicator of need for these types of services. And what you're going to see next is sort of an overview of just among home health users what their conditions and functional status looks like. So here what you see is that about 2/3 of all Medicare home health users have 4 or more chronic conditions. That's the orange part on the left side of the slide. Similarly, about 2/3 of home health users have at least one functional impairment, one ADL. So you know that when you're talking about home health, you're talking about a population that is often physically compromised, and although I don't have that up, the specific slide up here, cognitively compromised. So these are people with multiple challenges and the question is, how is it that home health can play a role in addressing their healthcare needs? We also know that home health use increases with age, and that is not particularly surprising. As people grow older, they are more likely to have functional impairments. And in fact, there's been some recent work, or not so recent work, that has shown that while functional status seems to not be declining among the younger elderly, it is increasing among the oldest old. So people are surviving, and people are living longer. But when they do, those who survive seem to be living with multiple problems. They survive their stroke. That's the good news. The challenge, the remaining challenge, is how do you live with the resulting impairments that require services and supports to maintain oneself. I do want to point out that home health also plays a role for people with disabilities, and I think there will be more discussion about that later, but we often talk in an aging context, and I think it's extremely important to point out about the needs of people with disabilities who are covered by Medicare. And just as home health use increases with age, the number of home health users, visits per user increases with age. So you can see an increase from 31, an average number of visits for 65 to 74-year-olds, to 37 visits for people 85 and older. I think what's also interesting is what you see below. If you can squint your eyes, and I apologize because it's small, but the range. I put up the 25th and the 75th percentile to see among people with relatively high use. The average number of visits is 42. This is the 75th percentile. So 25% of home health users have at least 42 visits, 36, 40, and 45 among 85-year-olds. Conversely, there are some people on Medicare in the bottom quartile who have relatively few visits, roughly 10, regardless of age. We also see that Medicare spending per user rises with age, not surprising because the number of visits increases with age, so it's pretty proportionate, although the slope is pretty gradual, but it is an increase. This next slide, which I know is kind of hard to absorb, but I'm going to try to go do it with you slowly, talks about Medicare per capita spending for different services. And what I think is interesting, let's start with the red line, which is home health. So what this looks at is average per capita spending for each service, and what you can see, it gradually increases with age. This is not a surprise, but it peaks at 96, which kind of interested us. We were sort of thinking it might have peaked earlier, but maybe that makes sense for home health, given that it is taking care of people toward the end of their life, and we know they have significant impairments. But I think the other thing to point out is that when we get, as people grow older, they're also using other services. So we're talking about a population that has sufficient impairments that they are using SNF services, home health services, physician services to a lesser degree, which is also kind of interesting and on point, that physician services peaks a bit younger. That's the blue line. You can see physician per capita spending for physician services peaks at age 83. And in contrast, home health services peaks at age 96. I mean, perhaps if that were a little bit more equalized, that might make a little bit more sense for an older population. But I guess the general point is as people grow older, they're using multiple services. And the question, I think, for you all to talk about in the next couple of days is there a better reallocation of services so that people are getting care in the most appropriate setting, they're getting good quality of care in the place where they want to be. That also sort of balances federal budgets, state budgets, and family budgets. Also of interest, and sort of follows naturally from the last slide, is we're talking about a population, it's 10% of the Medicare population roughly that uses home health services, but they account for 38% of Medicare dollars. Those obviously are not all home health dollars, but it speaks to the complexity of patient care for this population, and it raises questions, again, about whether they're getting the best possible care in the most appropriate setting, given their complexities, their age, their social situation. This home health service use has increased over time. This simply shows that the share of people using home health services has risen somewhat since over the past decade. Not a lot. I think you could anticipate that it would increase a lot. I think I need my water, sorry. I think you can anticipate, that is so much better, that the rates of use will increase over time as the population ages. Home health spending, I think you've already seen these numbers, but I'm just pointing out that home health spending has also increased as the share of Medicare dollars. It has leveled off in recent years, and there is some question as to why that's the case. Some of it may be due to the ACA payment reductions, although this only goes through 2012. It may be due to some of the fairly strenuous efforts to address fraud in certain pockets of the country in the past couple of years, but it is interesting that it has leveled off to the extent that it has. The other thing that's going on, and this was mentioned also in the last presentation, is sort of the big question about how home health will be fitting into all these new delivery systems that are being set up. I guess the great thing about having speakers do like overlap is it gives us all time to think about it. And really, I think this is a big issue because we are seeing pretty big changes in the healthcare delivery system. We now have 30% of all people on Medicare in managed care plans. We have the introduction of ACOs and pioneers, and whether or not they stick and last a long time is anybody's guess, but they are happening. We have bundled payment systems. We have integrated systems of acute and long-term care, particularly for the frailest dual eligibles being tested. We have team-based geriatric care. We have independence at home. We have a lot of ideas. A lot of flowers are blooming. I think it is really an important question about whether and how home health will fit into these various models of care. Home health agencies are not the biggest fish in the sea. There are big fish in this sea, and it is not clear to me how home health will play a role in the system as these big fish kind of fight for their share of the shark tank. And because of the important role that home health plays in the lives of people as they need it and they grow older, it really should be a key component of these delivery system reforms, and that will take some effort. So the demand for home health can be expected to increase. Everybody has mentioned this. Amy Berman pointed out that the octogenarians are really the crowd to watch. They will triple from 11 million in 2010 to 31 million in 2050. That's a lot of older people, right? Octogenarians, nonagenarians, centenarians. And home health is an important part of their healthcare delivery system. So you're kind of on the money in focusing on how care should be delivered in the future. And speaking of on the money, and I would imagine this may come up in the next presentation, there is the real question of how we're going to finance care for this aging population. It's not just a home health issue, it is an issue generally for people on Medicare. While Medicare is growing at historically slow rates, and Medicare spending this year is $1,200 less per person than CBO predicted in 2010. That's pretty phenomenal. There is still this sort of undeniable reality of an aging population with fewer workers available to support older people. So that raises a question that I think has to be put on the table, which is how the nation will finance care for an aging population, including but not limited to home health. So I think I have raised more questions than I have answered. I hope so. And I leave you with a bunch of questions to think about. How should home health be integrated into new payment and delivery system reforms? What should be the role of Medicaid, Medicare, and other payers? Should they be integrated? Should they remain siloed? If they are integrated, what are the pros and what are the cons? Should home health be considered, continue to be considered as a home health medical benefit, or should it be tracked a little bit more as a social service and thought of in that context? What more can be done to measure and improve the quality of care provided in the home by any of the providers? Earlier we looked at aggregate measures of quality. We're going to have to go dig a little deeper and look at variations among providers to sort of separate, figure out how to identify the best of providers and the providers that need more work, I think would be a nice way of saying it. And then again, how will the nation finance this tremendous need to provide care for an aging population, balancing federal budgets, but also balancing family budgets? So I thank you. I hope you find some answers, and I look forward to the discussion.